So, how do you manage atrophic gastritis and gastrointestinal metaplasia? How do you image it? How do you look at what are the precursors, and how do you signpost them? So, is it important? Yes, it's one of the precursor lesions of the upper GI tract. So it's a precursor lesion for gastric cancer. And how does that work? Well, yeah, you have Helicobacter is the overwhelming cause in this area of the world. Dietary changes in some parts of the world are very important. Of course, there can be patients with a family history. Patients can have pernicious anemia. Those are other causes. Patients can be using some reversible lifestyle factors that can be causing this problem. And they get initially atrophy, chronic inflammation. This sets up the development of clones of intestinal metaplasia. Each one is its own individual genetic clone. We know that from some nice data presented at UGW a few years ago. And so each clone goes in its own different direction and eventually at a certain point develops dysplasia or gastric cancer, but that's individual for the individual clones of intestinal metaplasia that develop. So what is the risk of patients having gastric cancer if they have atrophic gastritis or intestinal metaplasia? And it depends on, critically, it depends on the parts of the stomach affected. So if it's just the antrum, then that rate is low. If it's just the antrum, that the rate is low. If it's the rest of the stomach, then the rate is much higher. If you have just atrophy, the rate is lower than if you have intestinal metaplasia. And of course, if you have dysplasia, then the ship is sailing, right? I think it's fair to say. So yeah, the ship is not sailing at this point. You can do surveillance, but once the ship is sailing, you need to resect or remove or do something. I mean, I think that it's either one or the other, and then mild, moderate, or severe. So what does it look like? Well, here's some examples of the atrophic border. Here's some examples of what we've seen already today. We don't need to label these. I mean, this looks like a colon. I think this is a good way to describe it. There can be nodular, can be ridged, can have villus patterns. We saw yesterday a polyp in intestinal metaplasia. And then there are these findings of the real three types of intestinal metaplasia that you can see. So nodularity, light blue crest signs, or the white opaque things. And it's just best probably to show a photo. I see it here. So this is a nice summary of the different appearances of intestinal metaplasia. It'd be nice if this was an MBI image as well, because usually in MBI, you can identify nodules of intestinal metaplasia within the atrophy. So what it looks like is kind of more black nodules in amongst a white background. So that's I think someone was talking about that appearance yesterday. We saw it yesterday, and if you look back at the video of yesterday, the case in the afternoon, you will see that. And then you have this much more florid appearance. I showed a video of this yesterday with a hugely florid appearance of intestinal metaplasia all over the antrum and body of the stomach. And then you have the light blue crest sign or light blue crests here, which indicate the presence of intestinal metaplasia on the left, and on the right, the non-intestinal metaplasia mucosa. So this is very subtle. This is not very subtle, and nor is this. So you need to use all three types to integrate the presence of intestinal metaplasia. And then there are scoring systems, but they're all common sense, like all good scoring systems that tell you, okay, you've got, it's a very human thing, isn't it? Lots, not much, or none, and grade it based on the antrum, the incisura, and the corpus. And then you get a score out of that, which is a total of 10. If your score is 0, you have nothing. If your score is 1 to 4, we call it focal, moderate, and extensive. And what's the relevance of that? The relevance is that it predicts the rate of developing early gastric cancer. So if you have a EGM of 0, your odds ratio is 1, and that was the reference. If you have 1 to 4, your odds ratio is 12-ish. And if you have 5 to 10, your odds ratio is 21 of getting early gastric cancer if you have these degrees of intestinal metaplasia. So I think the age thing is very important. I think it's very clear if you have dysplasia that the age thing is not so relevant, because if you have dysplasia in a stomach, then, you know, things, especially if you have high-grade dysplasia, there's not much doubt that at a certain point there's going to be a major problem there. So it's easier. Yeah, indeed. Surveillance of antrum only, intestinal metaplasia or atrophy is out. I think if patients are elderly, what is elderly, that needs to be defined, of course, in a discussion with the patient, not just by you, but also the healthcare system, I think, in terms of money spent. And finally, if you have global atrophy or intestinal metaplasia without dysplasia, then I think you need to be careful with those patients. And so I think, yeah, the risk categories matter, and a discussion with the patient matters, and of course your healthcare system context matters in answer to that question.
PPIs.
Yeah, well, I think there's increasing evidence that PPI should be stopped in atrophic gastritis. As you said, because of the lack of acid production, et cetera, et cetera. Yeah, you have a hard time convincing patients, right? Because they've had their whole time, they've been told, yeah, just take a bit of PPI for your stomach pain or your dyspepsia. And it's not driven by acid, but that's what they're told. And they don't want to stop it. So I do try and convince my atrophic gastritis patients to minimize the use of PPI, but often you can't get them fully off it, because it's almost placebo for them that they need PPI for their very unhappy stomach or whatever it is that they call it.